Thank you for joining me today. I really appreciate it. I just wanted to ask you a couple questions as we get prepared for the Payer Summit this coming November 13th and 14th in Austin, Texas. So you are opening keynote for day two,
Yep.
and you'll be delivering a discussion about value-based care.
Mm-hmm.
Can you talk a little bit about why you think the adoption of value-based care is so important in healthcare today?
So anytime I'm asked about why value-based care and why I'm so passionate about it, I say, what's the alternative? The alternative, of course, is continuing the fee-for-service model that we've now had for decades, the procedure-based payment system that keeps getting us higher cost, often lower quality, more utilization, and just does not deliver better healthcare outcomes to us. And so the alternative is value-based care, and it can have many different iterations. It can be how we pay our payers, it can be how we pay our providers, but the idea is that we're paying for value instead of just paying for another procedure, more turning of the crank. As we'll talk about at the conference, there are so many of the incentive systems that get fixed in our healthcare system when you move away from paying procedure by procedure for everything. I mean, I get asked during COVID, we allowed home healthcare delivery, we allowed home hospital, we allowed telemedicine, and people say, well, why was it only during a national emergency that we allowed this? Why isn't this just part of how we deliver healthcare in our regular healthcare system? And I say the reason is how we pay for healthcare. Because when we pay by procedure, then the payers, including Medicare and Medicaid, get nervous about adding any new type of procedure, whether that's a home health care visit, whether it's a home hospital, whether it is telemedicine, because the view is it's just another opportunity to turn the crank, as I say, on more money, more revenue generation, not leading to better value and better outcomes. If we change how we pay, we get those types of alternative service delivery mechanisms, because that's how we deliver care, deliver services in every other part of the economy, but we get it with the right incentive structure and where it actually can decrease cost and improve quality of care.
Great. I love it. That's great.
You may need to add that one down. I got it.
No, that was perfect. Sorry. That was perfect. So this is it. I find this interesting because I was at HIMSS prior to this, so I've been in the, kind of on the outskirts of the healthcare industry for a while, and value-based care has been in the conversation for at least the past decade. So the question is why do you think it's still having such a hard time being implemented? There's fits and starts to it, but it just hasn't been a blanket utilization of value-based care.
We're talking about rewiring how every player is paid in 1/7 of the American economy. That's not beanbag. That is tough work. Mike Levitt, the secretary who I was the deputy to in 2005, really started us on this journey after reading Michael Porter's book from Harvard on competition and in healthcare. And Mike got us started, Secretary Levitt got us started on this journey. But remember, back then we're paying for procedures purely. And so you have to learn how to walk before you can run. You have to build muscle memory in doing new things. So let's say you want to pay for a hip replacement as a quality hip replacement versus a low quality, high cost hip replacement. How do you pay for a hip replacement? Well, before then, you pay for the device, the hip, you pay for the anesthesia, you pay for the diagnosis, you pay for the scans, you pay for the rehab, you pay for the actual procedure, you pay the hospital site fee. All these things, you have to figure out what goes into that. We called that the bundle. So you had to actually figure out what goes into a hip replacement before you could actually even assess which facilities are delivering lower cost, higher quality hip replacements. Again, that's not beanbag. That took a lot of work and a lot of time across the entire healthcare system to think about these alternative ways of paying for our various procedures that we have in our system. And so we started on that journey back in 2005, so almost 20 years now.
Yeah.
And then we start thinking about how do we pay providers differently. So we get into accountable care organizations, ACOs, and we're learning from this. Medicare Advantage. People forget Medicare Advantage is value-based care. It's paying a capitated amount of money to deliver care. So over time, we're learning and learning and learning. And then when I was secretary, I said, listen, we're going to, as they say, burn the boats. We're not going backwards to fee for service. We're being fully committed on this bipartisan journey to value-based care. And we moved to what we would call capitated provider payments. So we called it direct contracting entities. The new administration called it ACO REACH, same thing, different name. Basically, it's saying to primary care providers, we'll pay you a set amount of money for a Medicare fee-for-service beneficiary, and you decide how to deliver care working with that patient. You try to keep them out of the hospital, out of the nursing home, at home. You try to have points of engagement to deliver high quality care for those patients who need that type of intervention the most. And you get significant portions of the upside if you spend less money on that patient, and you get significant downside if you spend more money on that patient. And so it's the way to get the proper alignment of incentives. As I said before, think about just telemedicine. So when we're living in a fee-for-service world, the bureaucrats in Security Boulevard at CMS and the scoring people in Congress freak out. They get nervous about telemedicine because they figure you'll have an office visit and the doctor will just arrange for a ton of phone calls to generate more money. Well, if the doctor is getting paid, say, $12,000 a year for a Medicare fee-for-service beneficiary to care for that individual, that doctor then gets to make a bet. Is it more efficient, more effective, higher quality to have a telemedicine visit than having the patient come in person with all the time involved in that? That's their bet. They're not getting paid differently either way.
Right.
And so it leads to better technology and systems adoption than when we freeze things in place in a procedure-based way. But long-winded answer to say, this is complex stuff to make these types of changes. Hospitals, doctors, drug companies, insurance companies, everybody's making money in the current system. They don't want to change. So you've got to figure out, how do you, from your legal and regulatory and financial mechanisms, how do you orchestrate the largest, frankly, transformation in how we pay for healthcare since at least the 1960s?
Yeah, that's fascinating. Yeah, that is a challenge. Well, so leads me to our next question. So in broad strokes, if you can think of a couple anecdotes or instances, is where has value-based care been most successful? Where have you seen the greatest adoption of it and the greatest success?
So, I'm personally involved in a kidney care company, Interwell, and I've gotten to see the results there where, we are seeing across the board with the kidney care value-based arrangements that we created during my tenure as secretary. We are starting to see more home dialysis instead of center-based dialysis. We're seeing increases in transplantation, earlier transplantation. We're seeing slowing of progression of chronic kidney disease. And I hope by the time of our November meeting, when we're together, that we'll have some of the results out of the kidney care choices program, start seeing some of the data coming out of that by November when we meet together. I think I'm seeing it in another entity I'm involved in where we do this with managed Medicaid patients, where a managed Medicaid plan will take some of their sickest people, highest acuity individuals, and will contract with us to provide care for them on a risk sharing basis, where we work by building actual health centers in their neighborhoods and so providing social determinants of health, helping them with housing, social services, food, access to medicines, but also high touch repeat interaction, frequency of interaction to help keep those individuals out of the hospital, out of the nursing home. And we save money as a result of that. And these patients get, I think, frankly, a vastly better customer patient experience than using the ER as their primary care facility. So it's a win-win-win for the system and the individual overall. So I think we're seeing some real examples like that at the provider level. And then Medicare Advantage. People keep forgetting this. Medicare Advantage is value-based care. And Medicare Advantage is now the majority of our Medicare program. Our seniors are choosing it because it's the holistic way of financing healthcare that they are used to, so that they're not having a separate hospital program, a doctor program, a drug program, but rather what they're used to from their employer-based plans before they retired. And they're choosing into Medicare Advantage. And MA plans are basically capitated payers. They get an amount of money and they're at risk for either managing to that budget. And then they further capitate that money down in many instances to providers and put the providers at risk for delivering against those capitated MA payment rates themselves. So I think we're seeing a great amount of success. Are we there completely? No, we still have a journey to go, especially say with specialists.
Right.
You know,
Right.
specialists have a lot of market power because they provide something, by definition in the word specialist, they provide something that others can't deliver. But I think we're going to get there. I think we're going to get to where even specialists start delivering care perhaps as part of these direct contracting ACO REACH organizations, become preferred providers within those networks and have therefore an incentive to deliver care in a value-based way. And there are going to be other mechanisms that people smarter than I come up with, but we're getting there. It just, and in some respects, I complain about it being too slow sometimes. Everyone else complains about being too slow sometimes, but perhaps we should do a little bit more patting ourselves on the back that we have in fact transformed a great deal on this 19-year journey that we have been on, more than we give ourselves credit for.
Right. Right. Yeah. To your point, you're transforming a 1/7 of the economy. Like that's no small task.
Exactly.
So that's great. So this is a little self-serving, but I have to ask, just, you speak at a lot of conferences, I'm sure, throughout the year. So I guess I would love to hear, why are healthcare conferences important? Why do you think it's important to get out in front of your peers and talk like this?
Well, I think I bring something unique to the table in that I think, the first and only health secretary who led on the business side as well as the government side. So I was the president of the U.S. business for a global biopharmaceutical company. I've been in the private sector most of my career, but then I've also had an extensive career at the Department of Health and Human Services as general counsel, as deputy secretary, and then ultimately as secretary. Those are the three flags that you see behind me, one for each of those three offices that I held. And so I think I bring a unique combination of understanding the levers of government, the policy programs, but understanding the microeconomics that businesses face, the challenges they face within that policy environment, and how do those merge together. I teach down at University of Miami in the business school as an adjunct professor, and I begin almost every class saying, listen, no matter what you think about healthcare, whether you think of it as a moral right or about equity or whatever else, no matter what you think, if you fail to understand and appreciate that healthcare goods and services are economic goods and services and will follow economic laws, you will be sadly mistaken. And so I'm always trying to teach, whether at fora like we're going to have or in teaching, I try to always bring together the microeconomics, the real world P&L business incentives, and the policy environment. And so at a conference like what we're going to be doing to talk about value-based care brings that intersection together, of course, perfectly, the policy environment and the real world of care delivery. And so I think getting together both to teach, but also for me to listen and to learn, because I'm always trying to learn. This is a very complex space. Even as health secretary, I don't know everything in it. I'm always learning. So I think some of it's proselytizing for the future direction. I think some of it is making it known just how bipartisan a lot of what we're trying to do in healthcare actually is. That yes, we have our disagreements ideologically, but so much of it is grounded in just the basics of microeconomics, and that doesn't change based on your ideology. And then just that kind of networking and learning about new innovation. I'm in the business side now, so I get to network and hear who's got some great ideas and what are some interesting companies that may help change the world.
Right, exactly right. I love it. Well, thank you very much. Thank you very much, Secretary Azar. I appreciate it.